Today in this meeting, what we can talk about is ARDS, SARS, and COVID-19. So it's all very awkward name. So what this means. So something even more further relevant to this talk, for example, WHO, World Health Organization, UN, and CDC, FDA. So you need to learn the meaning of the abbreviation, then you will be able to understand what it really means. So I will go through how I learned the abbreviation of ARDS, SARS, and also this new COVID-19 disease. So I think for this new coronavirus disease, one of the most important breakthroughs to me is the definition of the name, definition of the virus. So we all know the virus is named as SARS coronavirus 2, but disease is named as a COVID-19. Why? So there's a reason for that, followed by that. So Li just introduced me as a faculty member in medicine. So I'm the director of IMS, so Institute of Medical Science. So many people are confused about what IMS is really does. So actually we are a graduate school training the graduate student within the clinical department at the Faculty of Medicine. So most of our students are in the teaching hospitals. But we do have a particular program called SIR. Again, another abbreviation. So stand for Summer Undergrad Research Program. So this program has been established over 40 years. Actually, this is the opportunity to give the undergrad student research experience, to let them to be involved in research at an earlier stage. Interestingly, 40 years ago when I was in China, I was one of the summer research students in China. So at that time, we already have this kind of a practice very similar to what we did here in the University of Toronto. In 1980, I was involved in the SIR, or Summer Research Program. The project I did is about ARDS. So since then, 43 years passed. So I feel sorry that we still haven't solved the problem for the SARS yet. But on the other hand, I can also feel that the public attention around this ARDS become more and more increasingly prominent. So what is ARDS? Actually, ARDS was a particular syndrome initially called Adult Respiratory Distress Syndrome. It was found by the American military in 1967 in Vietnam. So what happened is that the American soldiers was rescued from the battlefield, coming back, did all the surgery, all the rescue, and anti-shock, anti-infection. So eventually, the patient or the soldier becomes recovered from the injury. But then suddenly, the patient developed so-called wet lung, so the pulmonary edema. So at that time, the doctor called them shock lung. So after shock, that people develop this. Then later on, they call them adult respiratory distress syndrome, and then changed the name called acute respiratory distress syndrome. So very awkward, very hard for people to remember. So at that time, I was in China, so we were discussing about why we do not see the same type of patient in Asia, in China. So maybe this is something specific for the white people. So this is a real discussion at that time. So people try to understand what SARS, the ARDS is. So then go over on, so we learned more and more about the nature of this. Then what we learned is the lung actually is one of the most vulnerable organs in the body. Wherever you got, for example, you got burn, you got major surgery, you got a trauma, you got a stroke, you got an infection, then eventually your lung will get a problem. lung is very, very easily to get damaged. And then people try to dissect the lung injury with an intrapulmonary cause. For example, you can have a drawn, you can have an inhaled burn, and you can have extrapulmonary cause, for example, trauma, shock, major surgery, and so on. So then people further learn the reason for the acute lung injury is two reasons. One is excessive inflammation. So now from this coronavirus, you learn about cytokine storm. So that is one of the signs of excessive inflammation. The other is cell death. The cell can die in different ways. When enough cells died, then the lung cannot function anymore. Then people further learn the patient for ARDS actually is not dying through lung injury. Most of the time they die through multi-organ failure. So multi-organ failure is the reason for patient to die. So by learning this, one particular unit created in most of the hospital is called ICU, intensive care unit. Then one particular research or clinical discipline created called critical care medicine. So intensive care medicine depends on how you call it. So I'm a lung researcher, so in the lung research area, the most famous journal is called American Review of Respiratory Disease. But usually this kind of a journal published is supposed to be only review article, not original research article. So the society, the American Lung Association, American Thoracic Society decided to change the journal's name. So then they cannot find a better name until they named it American Journal of Respiratory and Critical Care Medicine. So that really emphasizes how important the critical care medicine means to a respirologist, means to a lung doctor. But no one can twist their tongue to pronounce this long name. So the cover of the journal is blue color. So now we actually, I'll call this blue journal. So they have a sister journal. The cover is a red cover, so we call it red journal. So people call it red journal, blue journal for the lung research. But now you understand it. For the lung research, there are two components. One is lung disease. One is critical care medicine. That's how important the critical care medicine means to us. So at that time, we also have a lot of discussion about the relevance of infection to ARDS. Because people know you could have a pneumonia, right? Pneumonia is basically a bacterial infection in the lung. So can we call a pneumonia ARDS? Some severe patient with pneumonia can also have a major problem. They cannot breathe, then they can die. But can we call that? Usually no. Usually we do not call pneumonia the ARDS. Why? It's because pneumonia is bacterial infection. By using antibiotics, you can get very effective treatment. Before the discovery of the antibiotics, the pneumonia also can lead to a huge number of patients to die. But with the new generation of antibiotics, then more and more patients will no longer suffer from the severe respiratory distress syndrome. So maybe the infection should not be kind of a part of the ARDS. This is the people's understanding. Until 2003, SARS happened. So SARS initially, I think Chinese people all remember, it's called atypical pneumonia, right? So actually, the atypical pneumonia by definition exists when I was a medical student many, many years ago. So usually it's induced by not bacteria, it's usually by virus infection. So atypical pneumonia has been exist for a long, long time, but people really did not pay attention to it until SARS happened. Why SARS is so different? SARS is also a typical, atypical pneumonia. What is the special for this type, this particular disease? Because it's induced by the coronavirus and has a very, very high mortality and very contagious to our population, and patients die and very, very badly. So how bad? Actually, for people who are younger people, you may or may not remember SARS in Toronto. I was here, and I remember badly that in Toronto we have over 200 patients, and approximately 50% of the patients were health caregivers, were people like us, doctors, nurses, front-line health caregiver. So that's how contagious it could be. So almost if you contact patients without protection, you will get it. So that's why SARS is so people are so frustrated about SARS. So then come up the name, severe acute respiratory syndrome. So it's the twist of the ARDS becomes SARS. So that's how SARS started. Fortunately, SARS is gone, but a lot of research actually conducted through the SARS, and people learned more and more about the virus, about the coronavirus, and other infectious diseases. And the lung critical care also become kind of a center of the world. So, of course, it depends on which doctor you talk about. If you ask Li, heart is the center of the world. But for me, in my center of my heart is the lung. The position, the twist depends on which type of doctor you are. So now come a question. Today, we get another problem very similar to SARS. Why we do not call it SARS? Why we call the virus SARS coronavirus 2, but we do not call the disease as SARS? So this virus, I think my colleagues for the infectious disease will talk more about the virus itself, had over 70% similarity with SARS. So overall, it is a variation from SARS coronavirus. So by naming this as a SARS coronavirus 2, it's a very, very good name and very accurate, reflect the biology, the nature of this particular virus. But why we do not call the disease as SARS-2 or new SARS? So some people call the new coronavirus pneumonia. Why we do not call them new pneumonia? We call them disease. So I don't know, I'm not part of the WHO panelists, but I think the name named is very, very accurate because it was induced by coronavirus, but it's a disease. So the disease 19 means 2019, so basically it's a year. So it's a disease, but it's not a severe respiratory distress syndrome. So it's not SARS. Two major difference. SARS, two keywords, respiratory, severe respiratory. So this is very, very important. But for the new coronavirus-induced disease, 80% of patients actually had mild symptoms, and 20% are very severe. So it's not everyone got a severe respiratory disease. So only 20% of them perhaps qualify for that definition. So this could be one of the reasons why we do not call that. And also for the patient who have a severe new disease, and they die through multi-organ dysfunction, multi-organ failure. So may or may not really die directly because of a respiratory failure. So that's could be another reason. So by precisely describe the disease with a proper name, it gives us a rationale how to deal with it. So that's why I think this is very important. By knowing it is coronavirus-induced disease, but this disease include people who had mild symptoms and even no symptoms, but are very highly contagious. But then also patients could have severe and respiratory and multi-organ failure. So in a way, it has a similarity with SARS, but also very unique feature. It is those unique features make us to decide how to prevent, how to treat those diseases. So that's what I can say. So that's also the reason I say, to me, the most important milestone for anti-this drug, the disease, is we named the virus, named the disease. So before I close my short introduction about the history, so you may ask what you do to help the situation. So CHR, the Canadian Institute of Health Research, pay great attention to this new disease, new infection. So they had an urgent call for research proposal. Many researchers in U of T, in Toronto, in Ontario, in Canada, actively put a lot of the research proposal, try to help. So I was involved in 2 projects. Actually, I was called by CHR, wanted me to serve on the review panel to review this proposal. Then I have to tell them that I'm also putting a grant myself, so I cannot be the panel to avoid the bias. So 2 projects, actually 3. So one project is we, in Toronto General Hospital, the lung transplant program, we developed a so-called Toronto Lung Injury Score, which is a basic panel of biomarkers that we can do a very rapid diagnosis within 20 minutes. We can do it on-site to tell this patient can go home for now, this patient should stay. So now we are collaborating with our Chinese colleagues from Guangzhou, from Dr. Zhong Nanshan, and also from Wuhan, from Tongji Hospital. So I had a research fellow in my lab, is Professor Xu Shuyun. She's a professor in Tongji Hospital. She's a respirologist. So her hospital already treated over 1,000 this patient, and she told us that over 800 of them a severe situation. Of course, only the most severe patient go to Tongji Hospital. Tongji, Xiehe, they are the Union Hospital. They are the best hospital. So they deal with the most severe situation. 62 patients in ICU, and also the most severe patients were treated with ECMO. So that's the information she sent to me. So we are trying to collaborate with them to test this rapid molecular diagnosis. That's one. The second project is I working with one of the scientists from Faculty of Pharmacy. Then she developed a new drug, which is a nano drug, which can kill the ROS, the reactive oxygen species, and also to try to stop or prevent the cytokine storm. That was the one I mentioned. So the third project is I have another colleagues who try to using the nitric oxide as a therapy to treat the acute injury. So we try very hard, and we try to raise the new therapy for this disease. But then you may ask, you may say, well, it's too late, and if you develop it takes time, it's too late. I don't think it's too late, because I believe now it still have 50,000 patients in China, more than 10,000 patients are still in a severe condition, and also now we heard the spread out in Japan, in Korea, in Iran, and other countries, and also we will have to be prepared in Canada, in North America, because the virus has no citizenship. They don't have a boundary, so they will go anywhere. Especially for the population like us, we are not very prepared. We are vulnerable to that. So that will be a really a problem. So how to deal with that? How to deal with the situation? I think my colleagues on the panel, they will address that issue. Thank you.